we're pretty good on the time at the moment. So our next speaker is going to be Dr. Mal Ameratunga. Mal's an academic medical oncologist in with clinical and research interest in neuro-oncology and early phase clinical trials. He holds a consultant oncologist position at the Alfred Hospital as the head of molecular oncology and rare cancers. Please welcome Dr. Mal Ameratunga. He's going to talk to us today about neuro-oncology clinical trials update. Thanks, Mal.
Thank you again, Marina, and everyone for giving me the opportunity to speak. So in terms of the structure of the talk today, I'm going to talk initially on a background on clinical trials in general, and then some of the specific issues that we have in relation to neuro-oncology trials. Some of the things to consider when navigating the clinical trials update landscape, and then finally a little bit of an update on clinical trials. It's not an exhaustive list, and does have a bit of a flavour of the trials that I know more about from a background of early phase clinical trials, and as a Victorian. So I think one thing to say about clinical trials is they're all targeting are in the clinic, so they're not preclinical trials in animals or in the laboratory. Before entering the clinic, there's extensive testing that's done to make sure that they're safe and the strategy has some chance of working. And they're traditionally grouped by phases. So traditionally phase 1 to 3, but we're seeing more of, particularly in brain cancer research, phase 0 clinical trials. So a phase 0 clinical trial is one where you've got a new drug that you given people prior to surgery. At the time of surgery, you use the samples to answer important questions about science, and then pair it with a phase 2 trial afterwards, seeing if the drug actually works in patients. Phase 1 trials are really first in human type trials where you're trying to figure out the type of dose of a drug to use in people for the first time. So when you come to any drug that's licensed that you use, they've got a label, all of that information comes from these early phase trials. So compared to other trials, there's more involvement from a patient point of view. So typically for the first month or two of participation, long days and weekly visits. So, they're a little bit more intensive, but very important to progress the field. Phase 2 trials we're seeing less and less of these days, but they're sort of where you've tested a drug, shown that it's safe in the phase 1 setting. You've got some evidence that it might be a strategy worth pursuing. You want to get more before doing larger and bigger studies to test whether the drug actually works. And then phase 3 trials are the trials that we think of prior to registration of a drug to show that the drug actually works. So in these trials are typically randomized. So, you get half or 2/3 or a certain number of patients will get the new treatment. The rest of the patients will get the old treatment, and you have some sort of parameters that you're measuring. In cancer research, it's usually how long you live, and show that the new treatment works better than the old treatment, and that leads to eventual registration. So in terms of this is a busy slide, but this sort of goes to the heart of some of the problems that we've had in brain cancer research. And this is really a short history of brain cancer trials from the 70s through to today. And this is not expecting you to read that. I'm going to point out a few things. So firstly, recently in the last decade, we have had some really big phase 3 trials where there's a lot of hype that it turned out negative. So a few that I've highlighted there were different types of treatments to target that EGFR that Ben alluded to. So, that's an aberration that's very common in higher grade brain tumours. And also immunotherapy. And immunotherapy is sort of worked in pretty much most tumour types, and brain's one of the places where it's really a small subset of patients that are finding benefit, or certainly at this stage. And that's not including some of the earlier studies of things like bevacizumab. which is used widely, but have failed in sort of bringing it forward in first-line settings. And one of the factors, one of the negative factors of this is that this discourages investment from pharmaceutical companies, which are very much needed to actually get things going. But hopefully that'll change. The second thing is there's long lag times. So in low-grade tumours, you can live for a very, very long time. And what that means is that, it can take forever to find out if these things actually work. So one of the studies there, it started accruing patients in 1994. In 2006, when in low-grade tumours, when they initially reported results, it wasn't clear that it was beneficial treatment. And it was only 2013, almost 20 years later, that there was actually a very, very clear signal that things worked. So that's one side of the coin, is that it can take a long time to actually get answers from a trial. And then you've got to figure out what to do. And we can't wait another 20 years to figure out how to deal with low-grade tumours now that we've got IDH inhibitors. So figuring out how to do that is a problem. And then the second thing is, and this is, the science that we're doing today takes a long time to be translated into the clinic. And this is actually really impressive that IDH mutations really identified in 2009 in gliomas, and we're getting a phase 3 showing benefit in 2023. So that's actually a really short timeline. But again, from a patient point of view, that's still slower than we want. One other factor that's sort of more of a technical thing, but something to think about, and there's a lot of learning from our side, from clinicians and researchers in designing things. Interpreting scans for brain tumours is more complicated than tumours elsewhere in the body, and you can get things like it looks like it's getting better, but it's not, or it looks like it's getting worse, but it's not, and so that's resulted in a set of criteria that we typically use for clinical trials called the RANO criteria, and that gets updated continuously as we learn more. So we learn from these sorts of things, but there have been mistakes made in the past because we didn't know about some of these factors. But yeah, the thing probably at the end here is that some green shoots. So the cadence of approvals, including brain cancer indications, has definitely increased. So you've got a couple of approvals in the last couple of years in the US, not quite here, but as Ben talked about, in BRAF mutations, which is a subset, we've got dabrafenib and trametinib approved for all tumour types, including brain cancers, or all tumour types bar, 1 or 2, but brain cancers are included. And then the Indigo study for vorasidenib in IDH mutant glioma, which is predominantly low-grade tumours, that it's just recently been FDA approved. So these, are definitely green shoots. And then the good science that's happening today, there will be a lag, but that, things will come from that, or hopefully. So in terms of navigating clinical trials, something to think about is the setting, and it might not be intuitive to people that aren't involved in clinical trial research, is that most trials will be targeting a specific population. So it might be people who've never had treatment, people who've had, one type of treatment or 2 types of treatments. And so you can only really generally qualify for a trial at a time where there's a treatment change. And so if you go on one treatment that, everything that targets people that are untreated will no longer be an option for you. So that's called the setting or the line of treatment. So a good time to think about trials is sort of in between, and in between those decision points. What I talked about before, that those complications in interpreting imaging and scans, that can lead to some funny situations. Like you can have a tumour that might be growing but not qualify for a trial because it's not bad enough to actually qualify for it. So there are like technical things that that are very non-intuitive, that do come up because of the you have to actually answer the research question at the end of the day so that you can actually get the drug approved, etc., etc. Then there's things like standard exclusion criteria. So generally, and it's not really a problem we see that much for brain in neuro-oncology compared to other cancers, but you need normal organ function, sort of liver and kidney and etc. But then there's also relating to the type of trial. So if you're going on an immune trial, which is stimulating the immune system, if you've got other immune conditions, that might be an exclusion. Or if you're getting a drug that, you know, in the animal studies has shown that it might increase the risk of bleeding. If you're on blood thinners, that might be an exclusion. So there are things that are specific to the trials as well. In terms of public information, so the accurate information sources I'd point to are the clinical trial registries. So at one point in time, if the information on that is correct, so the Australian one's the Australian ANZCTR, New Zealand Clinical Trials Registry, and then American one's clinicaltrials.gov. There's a European one as well called UDRA-CT. They will usually have the information when the trial's opening, be correct and up to date with regards to that, but they're not sort of updated in real time dynamically. So, you know, you also need local on the ground information from wherever the trial is actually happening. So Ben also alluded to molecular profiling of tumours. So we're very, very lucky in Australia. We've got sort of access for pretty much anyone with a tumour to comprehensive molecular profiling through the CAS program. It does take a little bit of time. It can take, you know, 4 weeks if it's quick, but it can take longer than that to actually get sequencing done. It's free. For pretty much, yeah, it's free and it's good. It's very good sequencing. So, you don't want to be making decisions on that information when it's going to take a little bit of time to come back. So, again, these are things to think about when discussing the trials that may or may not be available. And if in doubt, always your oncology, your team is usually on top of this, and don't ever feel afraid to ask. So then, briefly, this is a clinical trials update. It's not exhaustive at all, and I actually tried not to cover too many of the studies Ben talked about last year. I understand the slides are available. So there are many other studies that I haven't referenced here. So I've gone through in the phases that I talked about earlier in the talk. So some interesting phase 0 studies that are sort of propelling science in the space. So at Peter Mac, there's a perioperative study of an IDH inhibitor called safusidenib that, they get a biopsy, confirm that it is the target that they're trying to hit, then get pre-treatment, have surgery, and then you get a follow-up of treatment for afterwards to see if the drug actually works. And they've already sort of published some initial data at ESMO talking about the science, and you get really good information like whether the drug's actually getting into the brain tissue and whether you can actually go, oh look, this drug works by doing this. Is it doing this in the tissue? So you can actually answer that question if you design a study like this. And sort of a more advanced study, niraparib, the phase 0 and phase 2 results have already been reported, and shows that particular PARP inhibitor, which I'll talk about a bit later, does cross the blood-brain barrier, and that's led to a phase 3 study that's about to start. So important studies give us important information on how and we can learn during the study as well. This is a new target that I think is worth keeping an eye out. So MTAP is a gene that's deleted in a lot of cancers, 15% of cancers. In brain tumours are one of the top most represented for that particular gene mutation. And the reason why it's so common is it's right next to a really, really, really important gene, like it's adjacent to it. And so it's often lost with that other important gene, CDKN2A, which came up on Ben's list a few times. And so the reason this is important is one of the strategies that one of the holy grails of cancer drug development is getting a drug that can hit cancer cells and not and keep your normal cells healthy. And so if you have a deletion in MTAP, you become more dependent on other elements of that particular pathway that are needed for cell survival and metabolism and a lot of other things. And so if you hit the cancer cells, which lose MTAP because there's got this other really important gene next to it, they become dependent on PRMT5 and M2A, MAT2A, and for metabolism, and they've probably got enough residual activity, which you can see in the bottom left of that, the first figure there. They've got residual activity that allows them to grow, but if you add in inhibitors of those other enzymes, you actually get below the threshold that they can grow and can actually cause cancer cell death. And so these drugs, there've been multiple drugs that have shown promising results in phase 1 trials. And it's always good when you've got multiple drugs that show the same thing for the same strategy. That means it's more likely to work. Not all of them cross the blood-brain barrier, but there's several of these that are either in phase 1 or coming into phase 1. Now, this is also something technical to think about with your treating doctors. MTAP's not tested on all the assays, so if this is something that may be of interest to you, you have to just check, was this actually tested on the assay that you had, including some of the best assays. So that's one that's we've got a pretty good line of sight on trials that are coming through, and there's a lot of these studies coming through at the moment in the early phase space. A quick update on some of the other sort of phase 1 trials, and again, this is not exhaustive. You've got a radionuclide therapy up front, targeting a protein called LAT1 at the Austin in Victoria. Study that we've got, a small molecule inhibitor of EGFR that's clearly brain penetrant. And you've got immunotherapies as well, so up at QIMR, tumour infiltrating cells with immune therapy to try to stimulate the immune system to fight cancer. And there have been some interesting results, early days, very, very early days, of new types of treatment and strategies overseas. So 3 out of 4 patients with glioblastoma and MDM2 amplifications. This is a different pathway that's sort of less common than the one that I alluded to before. Had regressions, so that was an Aztecs compound reported earlier this year, and it's gained a lot of press, but intraventricular, so into the brain, CAR T cells targeting EGFR also achieved some responses in a very, very small number of patients in the US. So again, some diverse range of strategies that we back as many horses, and whichever ones work, keep progressing through the phases to phase 2, 3, etc. So this is a bit of a different one. There's not many phase 2 trials floating around, but the ketogenic diet, which is of interest to a lot of patients, relies on the fact that cancer cells preferentially need glucose, and other cells, healthy cells, can rely on ketones and other sources of energy. And when you starve them of glucose, cancer cells can't switch that easily. The team at Cedars-Sinai have led a lot of the promising work on this in brain tumours, and published or presented their phase 1s, 17 patients, but sort of much better outcomes than historical controls, which have led to their phase 2 study, which is open in the US last year, called Diet to Treat, and it'll be very interesting to see what the results of that are. Again, several years away, but ongoing. And then phase 3, so study that we've got opening up very, very shortly, is of the PARP inhibitor niraparib in the first-line setting in patients that are predicted not to benefit from temozolomide. And again, in the phase 1 from phase 0-2 study, they had outcomes that were substantially or double what they were expected from control, historical standards. And they're hoping to replicate that in the phase 3 study. And again, this relies on that concept of synthetic lethality, which means that you're targeting, DNA damage repair, and so cancer cells will have defective DNA damage repair because that helps them grow, and radiotherapy can kill cells, and PARP inhibitors will stop that DNA damage repair further. And then finally, just a quick update. So, this is not clinical trials, but special access schemes. There's, again, been a little bit of improvement, actually a lot of improvement in this in the last 12 months as well. So, targeted therapy, so BRAF inhibitors. If you've got a mutation in one of these rare things, it's not approved in Australia for brain tumour use, even though we know these drugs work. We've got a study that will open up later next year, but there's also compassionate access schemes available for free. There's for H3K27M mutated glioma, which is extremely rare. The access scheme only opened up this year for Onc201, and vorasidenib for IDH1 mutants only opened up 2 or 3 weeks ago. So again, progress. That's all.
Thanks, Mal. The one thing that stuck out to me in that slide was that we only added radiation to brain tumours in the 70s, not so long ago. So we do, even though we feel sometimes that things don't progress along very quickly in regard to trials and access to drugs, I think, to some degree when you look at that, it has.